Hi friends, in our series of graph related discussions, in this video we are going to discuss another very important graph, and that is Frank-Starling curve. Clinically very important because there are changes that happen in this curve with heart failure or with exercise and positive inotropy. So let's begin. But before we start, let me just remind you that we have started new sections on our channel like clinical case-based MCQ discussion, daily MCQ uploads, and periodically we conduct the quiz contest with grand prizes to win. So it would be a good idea to subscribe to the channel. All right, now let's start from the basics and build the topic, and then we will talk about the graph. Starting with the Starling's law. For the skeletal muscle, I have often seen that the students are confused between the two terms, length and strength. They often end up saying length of muscle fiber is proportional to strength of contraction of the muscle, etc. That means they have not understood the concept. So Starling's law for the skeletal muscle talks about the strength of contraction of the muscle. The whole discussion will revolve around the strength of contraction of the muscle. Now, Starling's law states that strength of contraction of a muscle is proportional to the initial length of the muscle fiber. Initial length of the muscle or of the muscle fiber or of the sarcomere. All right, and add three more words in the end: within physiological limits. I'll tell you the importance of these last three words, but let's understand in detail this Starling's law. We are talking about how strong a muscle will contract. It depends on various factors, but we are talking about the length of the muscle fiber. Let me also explain. Length of the muscle or length of the muscle fiber inside that muscle, or inside the muscle fiber there is sarcomere, so length of the sarcomere. Any term would be acceptable. So the point is, it is the initial length of the muscle or muscle fiber that determines the strength of contraction of the muscle. Greater the initial length, now this part is important, greater the initial length, stronger will be the contraction. What do you mean by initial length? When the muscle is beginning to contract, when the muscle is starting to contract, at that moment, what is the length of the muscle fiber? Greater that length, stronger will be the muscle contraction, of course within physiological limits. Why does that happen? It's because when there is a greater length of the muscle fiber, then there is a better actin-myosin interdigitation, and if there is optimum actin-myosin overlap, or rather actin-myosin interaction, then there is a stronger muscle contraction, and therefore that's the Starling's law which applies to the skeletal muscle. I repeat once again so that you can reproduce it in the vivas. Strength of contraction of a muscle is proportional to the initial length of the muscle fiber. Greater that initial length, stronger will be the contraction, but within physiological limits. All right, it's not as if you go on stretching the muscle and then make it contract, it will contract stronger. There is some physiological limit to it. Okay, now coming to the Frank-Starling law. So it is in a way extension of the Starling's law. Starling was Ernst Starling, E.H. Starling or Ernst Starling, and then Otto Frank and Ernst Starling gave this law, which is Frank-Starling law for the heart. It is in a way, as I said, extension of the Starling's law. Let's see how. Well, the law says that more the venous return to the heart, more will be the cardiac output given by the heart. More the blood returning to the heart, more will be the blood pumped out by the heart. But again, within physiological limits. All right. So let's understand this Frank-Starling law. Okay. Cardiac output I'm mentioning as the blood ejected out by the left ventricle per minute, and in single beat the blood ejected out is the stroke volume. So we can say that more the venous return to the heart, more will be the stroke volume given out by the heart, and also the cardiac output will be greater. Okay, now I am further advancing this law. It says stroke volume is proportional to the end diastolic volume in the left ventricle. So what is end diastolic volume? It is the volume of the blood in the ventricle by the end of the diastole. So you understand this part, that more the venous return, that means more will be the ventricular filling. You can see here, more the venous return to the heart, greater will be the blood filled into the heart, into the left ventricle. That means by the end of the diastole, more blood will be filled in the ventricle, increased end diastolic volume. You can see here, greater blood filling in the ventricles. That means there is more and more blood filled, and by the end of the diastole, volume will be greater. That's greater the end diastolic volume, which also means greater will be the end diastolic length. Yes, you can imagine here, if more blood is filling in the ventricle, ventricle is expanding more and more during diastole, and if it is expanding more and more during diastole, its length is increasing, and as its length by the end of the diastole, its length will be called as end diastolic length of the ventricular muscle fiber. So more the end diastolic volume means more is the end diastolic length. More blood filled, ventricle was expanded more and more during diastole. So by the end of the diastole, its length, ventricular muscle fiber length, will be that much greater. And you also know that ventricle is alternately going into systole, diastole, systole, diastole, systole, diastole. So by the end of the diastole, the fiber length is some length, and then the next systole starts. So that next systole will start with that length which was there in the previous diastole. By the end of the diastole, what was the length of the ventricular muscle fiber? That will be the starting length for the next systole, obviously. So if greater the end diastolic length, that means greater is the length for the next contraction. At the start of next systole, next contraction, there will be a greater length of the ventricular muscle fiber, and greater length will produce, of course, stronger contraction. Yes, stronger the contraction with the next systole, because at the start of the systole, the ventricular muscle fiber was that much greater. And if it's a stronger contraction with the next systole, there will be a greater stroke volume. Now this is logical. Stronger the ventricle contracts, more will be the blood ejected out by the ventricle. Easy. So you can see here that the stroke volume that is ejected out is proportional to the end diastolic volume or end diastolic length. They go hand in hand, of course. So that's another interpretation of the Frank-Starling law. That is, stroke volume is proportional to the end diastolic volume and end diastolic length. The only thing that was to be understood here clearly was that the end diastolic length is the length for the starting length for the next systole. Once you understand this, then it's a piece of cake to understand everything. All right, let me just add one more entity here. We have talked about the end diastolic volume, okay, and end diastolic length. They go hand in hand. I'm adding one more entity, and that is end diastolic pressure. End diastolic pressure. Pressure of the left ventricle or pressure inside the ventricles by the end of the diastole. because if more blood is filled in the ventricle, then the ventricular pressure will also increase. More blood filling, more end diastolic volume, so end diastolic pressure will also be proportionate to that. Greater pressure because greater blood has filled in the ventricle. With this background, now let us talk about the Frank-Starling curve. What are the units on horizontal and vertical axis? On the horizontal axis, we have left ventricular end diastolic pressure, LVEDP. I am taking it in mm of Hg. Some people take it in centimeters of water. That's okay. So left ventricular end diastolic pressure, or you can also take left ventricular end diastolic length. That's fine. And on the vertical axis, we have stroke volume. Stroke volume produced by the left ventricle in ml, 50 ml, 100 ml. Let's see how much is the normal stroke volume. Now, when we plot this curve, if the curve is going up on the vertical axis, that means stroke volume is higher and left ventricular end diastolic pressure is less. And if the curve is going flat like this, that means left ventricular end diastolic pressure is increasing and increasing, but the curve not going up on vertical axis, that is stroke volume is not increasing. So let's see what happens in the normal heart. You can see here in the normal heart, this is the curve in the case of normal heart. So you can see two parts here. One part here and the other one is little flat towards the end. So you can see the initial part rising like this, meaning that the stroke volume is increasing for an increase in the end diastolic length of the ventricular muscle fiber. So greater the end diastolic length, stronger will be the next systole and greater stroke volume ejected. So this part is called as preload dependent part. End diastolic volume is also considered as the preload on the ventricle. Okay, and the other part, later part, is preload independent. It tells us that even if end diastolic length is increasing, the stroke volume is not increasing in proportion to that. Well, so that's the curve in the normal heart, in the case of normal heart. Let's chart out the stroke volume here. Up to this point, we certainly have preload dependent contraction of the left ventricle. So somewhere here, 80 ml is the stroke volume, which is the normal case. In a normal heart, the stroke volume is 80 ml. And this point corresponds with how much left ventricular end diastolic pressure? About 5 to 10 mm of Hg. You can see here in the graph, 80 ml stroke volume. This point we are considering as the mean point for this curve. So this point corresponds with 80 ml stroke volume, and on the horizontal axis it corresponds with the about 5 to 10 mm of Hg left ventricular end diastolic pressure. So normal left ventricular end diastolic pressure is in the range of 5 to 10 mm of Hg. What happens in the case of heart failure? You can see here that the curve shown in the yellow is the curve for heart failure. It's a flat curve. So what that means is on the vertical axis the curve is not going up, and on the horizontal axis, that is left ventricular end diastolic pressure, is increasing 10, 20, 30 mm of Hg on the horizontal axis. This is the mean point of this curve. So first note, the curve has shifted rightward and downward in heart failure. So this is also called as negative inotropy. What is inotropy? Myocardial contractility, strength of contraction of the heart, strength of contraction of the myocardium, which is what we are talking about. Negative inotropy means strength of contraction of the heart is decreased. So that is what happens in the heart failure. Heart is failing as a pump. Its strength of contraction is becoming less and less, and therefore it is ejecting out less and less stroke volume. So check it out here. This point in the case of heart failure curve corresponds with about stroke volume of 50 ml. Yes, stroke volume has decreased, and that means the heart is failing to pump. It's a heart failure condition. And it corresponds on the horizontal axis, this point corresponds with about 20 mm of Hg of left ventricular end diastolic pressure. 20, 25, it can even go up to 30 mm of Hg, as you can see in the curve. Left ventricular end diastolic pressure increases in heart failure. That's the point I'm trying to make. Stroke volume decreases because heart is failing as a pump, and LVEDP increases, end diastolic pressure increases. Why is that? Now consider this. Stroke volume is less in heart failure. That means what? By the end of the systole, more blood remains in the left ventricle. I repeat again, left ventricle is ejecting out less blood during systole. That is, stroke volume is less. That means by the end of the systole, more blood volume stays behind in the left ventricle. Then it goes in the diastole, it receives its normal quota of blood. Therefore, what happens is its volume, left ventricular end diastolic volume, goes on increasing. And therefore, because more and more blood is staying in the left ventricle, by the end of the diastole, its pressure also increases. Left ventricular end diastolic pressure is high in the case of heart failure. Now that is clinically the most important point to be considered in the Frank-Starling curve. In the case of positive inotropy, just let's add here, the curve will go leftward and upward like this. So positive inotropy will appear like this. During exercise, during sympathetic stimulation, then giving digitalis, which is a positive inotropic effect on the heart. In all such conditions, the curve will be like this. It will go upward, leftward and upward. So that tells us the stroke volume becomes 100 ml and left ventricular end diastolic pressure is 5 mm of Hg, not rising much. So positive inotropy is a good condition. Heart is contracting stronger. That's what positive inotropic effect. And stroke volume is higher. That is what is shown in the third curve. All right. So that was the Frank-Starling curve, and it's the effect of heart failure and negative inotropy on the stroke volume and LVEDP. Just adding further, very often this question is asked, whether failing heart, does it obey Frank-Starling law? Well, at least initially, the failing heart does obey Frank-Starling law. What happens is, imagine that the heart is failing. That means pump failure, systolic dysfunction. So less amount of blood ejected out, stroke volume is less. That means by the end of the systole, more blood stays in the left ventricle. Then ventricle goes in diastole and receives its normal quota of blood. So by the end of the diastole also, extra amount of blood, greater amount of blood in the left ventricle. Which means what? Left ventricular muscle fiber is stretched to a greater extent, isn't it? We have seen that more the end diastolic volume, more will be the end diastolic length. So in the failing heart, at least initially, this compensatory mechanism sets in. Less stroke volume ejected out because pump is failing, heart as a pump is failing. So by the end of the systole, more blood in the left ventricle, then it goes in diastole, it receives its normal quota of blood, and therefore end diastolic volume is also greater, end diastolic length is also greater, it has increased more than normal it is, and therefore with the next systole, by Frank-Starling law, it will produce a stronger contraction and will try to eject out more stroke volume. So yes, failing heart does obey Frank-Starling law as a compensatory mechanism in the initial period, and which is what is written here, pump failure, so reduced stroke volume, so therefore there is greater end systolic volume, then that means there is also greater end diastolic volume, and stretch of the myocardium is greater, so it will produce stronger contraction in the next systole to compensate for a failing heart. This is the case with heart failure, and this is what is indicated by the Frank-Starling law or Frank-Starling curve, with the normal curve and the curve that is seen in the heart failure.